I just wanted to update you on a couple of pieces of good news. Probably the most important piece of good news is the state budget. As you know, the Connecticut Mental Health Center was in a series of budgets slated for a cut of about $1.4 million. We were able to overturn that. There's a minor rescission in the budget, but we will live to fight another day, which is great news, and I appreciate the work of our faculty, trainees, and everybody who got involved in advocating on behalf of this institution. Another piece of good news from the state is that the state and Yale New Haven Hospital are going to work together on a major genomics initiative, and we hope to be a part of that. Another seasonal bit of news is that yesterday we had the kickoff day of interviewing our new crop of residency applicants. Once again, we have somewhere around 1,300 or 1,400 applicants for our 16 spots. We've winnowed down the group to about somewhere between 100 and 150, something like that. And they're starting to come through. They're as exceptional and interesting to talk to as they always are. And I do not envy the committee that has to select from this group to rank them. But I want to thank you in advance, all of you who are involved in the residency interview process. The quality of our trainees depends on the quality of the experience that they have when they visit. So having a good experience with us ensures that the next year's group of residents will be as exceptional as previous years. Two other pieces of good news. Hillary Blumberg last Friday received the BBRF Mood Disorders Prize. That's a big, important prize from the Brain and Behavior Research Foundation at the Pierre Hotel in New York. It was a wonderful event and a wonderful honor. And also Amy Arnston, who's in the Department of Neuroscience, but who also has an appointment in the Department of Psychiatry. It was just announced that she was elected to the National Academy of Medicine, so wonderful news for her. So lots of news, and with more news to come, we're thrilled to have two guests today to present our Grand Rounds presentation. Mr. Rick DeQuilla, who's the president of the Yale New Haven Health System, and Dr. Tom Balcezak, who's the chief medical officer for the system, to tell us the exciting news at Yale New Haven Hospital. And we're thrilled to have you here and look forward to your presentation. Thank you.
So thank you, John. So the pressure's on to keep the good news coming. We'll see. That may be kind of hard to do, particularly with the state of Connecticut. Can you hear me okay? So Tom and I are here, and also Mike Holmes is here. And what we want to do with the time that we have is give a very brief update on the hospital's 2017, our priorities for 2018, and a special focus on the high reliability work. But you know, we want to accomplish the impossible, I think, in an auditorium like this, is have as much interaction and Q&A as possible. That is really what we hope for in all of these grand rounds, is really an opportunity to share where we are and where we're going, but also get a sense of what questions you have, and use at least half of our time for that. So what I'm going to do just very quickly is these are the only data that we're going to share. There's a lot of numbers. But we really look at kind of 4 dimensions of the numbers that matter, and really track how do you summarize a year as busy and as challenging as 2017 is all the years that we have. There are really kind of 4 dimensions that we focus on. We look at how we're doing in terms of patient safety and our work around high reliability, how we're doing in the patient experience, how patients are rating the experience, our growth and our volume, and how we balance the financial elements of those equations. And I'll touch quickly on each of these. There is actually a lot of good news here, particularly when you step back and look at the challenges that are facing healthcare in Connecticut. Connecticut is a very difficult and challenging environment. It's a very difficult, I don't have to tell you this, it's a very difficult and challenging time in Hartford and in Washington. And we stick out because as an academic medical center and as a safety net hospital, we are particularly vulnerable to, to all that means in terms of how expensive we are as an institution, and how important we are as a safety net that takes care of patients regardless of ability to pay. In the face of all that, we have some great progress here. Tom will spend more time on this. There's been a multi-year effort here to focus on eliminating events of harm, and 2017 was another record year in driving that number to zero. And I don't want to steal Tom's thunder, but of all the numbers that are on this panel, this is the one we're most proud of as a leadership team. Patient experience, how patients rate the care and the experience, everything from food service to parking to communication to their interactions with the healthcare team, kind of a mixed bag. We have put an enormous amount of work into this. You all have put an enormous amount of work into this, and we have some units and services that are literally in the top 5th percentile nationally, and others that are not, that are at the other end of the spectrum. So the averages don't tell the whole story. We still have work to do here as an organization, because this is an area where every institution is focusing aggressively on the patient experience and making progress. Bottom left are volume trends. We are an anomaly. Yale New Haven continues to see volume growth and continues to be an extraordinarily busy hospital from both an inpatient hospital perspective and an ambulatory perspective. Now, I know you live that every day. You're always, inpatient behavioral health is always packed, but that's not the case in other services and service lines. A lot of hospitals are experiencing shrinkage and volume shifts. A lot of what has traditionally been done in inpatient care is moving to ambulatory settings. We're bucking that trend with particularly with our transfer volume. And what collectively we've built as a destination hospital and as a transfer center, we're changing dramatically in terms of acuity, patient mix. So just to give you a couple of examples of that, we 3.5 years ago built a transfer center called Y-Access that takes patients from all over Connecticut and beyond in a very facilitated manner. And that volume has grown now to nearly 700 patients a month. And every month it continues to grow. On any given day, we have 1,400 beds in operation, and 200 of those beds are occupied on average by transfer patients. That's had a tremendous impact on the acuity. These are the sickest, most complicated patients, and again, it's had an impact on our volume, which helps us deal with the other shifts of shrinking payment, and at least we're not shrinking on the volume side. Outpatient volume also continues to grow as we build ambulatory facilities across the shoreline and beyond. And some of our relationships, like the ambulatory services we have in cancer care with organizations like St. Francis Hospital in Hartford. And lastly, we're able to still, with the cuts and the state taxes, we're still fortunate to be able to have an operating margin again in 2017. Don't confuse that with profit. An operating margin, in this case, about 3.5%. is the excess that's left over after our expenses, and every penny of that is invested back into our organization and then some. This is just some examples of where the margin went from 2017 to 2018. That's what we invest in ourselves and continue to grow. And what you're going to notice right away is the number of the investment dollars are bigger. We're like the average American household. We spend more than we take in. Some of our investments are financed, but our margin does not cover the money that goes back into grow, develop, build our workforce, keep our capital and our facilities modern. That's the reality of the environment that we're in. And it's why it's really important, whenever you hear out there, Yale New Haven Hospital is making money, remember that that's a very deceptive characterization. The margin that we generate is not profit. We're a nonprofit institution. We take care of patients regardless of their ability to pay, and every dollar and then some gets invested back into our institution. It's how we grow and stay strong as an organization. 2018 is another growth budget for our organization. It invests in clinical services. We're doing a lot of work to develop our more of a care system and a signature of care across our health system. Michael's been leading that with Dr. Crystal in behavioral health and a great degree of integration with Bridgeport and with Lawrence and Memorial. Dr. Crystal mentioned the Center for Genomic Health, which is a major investment with Yale Medicine in 2018. And a lot of technology investments. We've made a lot of investments in the St. Raphael's campus, which had a lot of needs for infrastructure and a lot of needs for clinical infrastructure. Diagnostic facilities, operating rooms, a big investment in musculoskeletal care. So I think the thought I want to leave you with is that in an environment with a lot of challenges, we are still making investments and we're still focused on growth. And I honestly believe that's not the case in many hospitals and many health systems across the country because the payment and the financial environment is such a difficult one. So no shortage of challenges in 18. We continue to see shifts in reimbursement. Our Medicare and Medicaid payments continue to shrink. Connecticut is a very competitive landscape. There are a lot of things that are moving out of the hospital into private facilities. There are a lot of competitive challenges. The federal and state political environment, probably we could spend an hour on that and you could help us understand it. But there's a lot of craziness in terms of really destructive shifts in payment and underpayment that have a profound impact on the patients that we take care of. We are working on health system integration. I mentioned that, and as next year and the years that follow play out, much more of a focus on one standard of care and one clinically integrated focus that really drives from Yale New Haven Hospital across our health system. And then just the constant balancing act of what we are. We are not simply an acute care hospital. We're not simply a health system. We have a clinical, academic, research, and community-based roots that all need to be balanced. That kind of make us great, but also make us challenging to move forward in that environment. And yet again, it's a constant balancing act. I'm going to turn it over to Tom to focus on safety and quality, and then we'll open it up for questions.
Thank you, Rick, and good morning, everyone. Thanks for spending some of your valuable Grand Rounds time with us. Rick and I have been going to all the clinical departments over the past year, and you guys can either qualify yourselves as the last of the clinical departments in 17 or the first of the ones in 18. We have a couple challenges in getting in front of you. But we really would very much like and would be honored by having a little more time to spend and engage in this dialogue that Rick just outlined. It's really important to us that you hear and have opportunity directly with us to talk about what our strategy is, what our challenges are, and whatever questions you might have about what you might be hearing in the news, and give us an opportunity to engage in that dialogue. So we're going to keep our presentation and our prepared remarks relatively short, and then allow time for Michael, Rick, and myself to answer any questions. So this first slide is about our safety and quality priorities, and this is really the foundation of what is important to us at the hospital, the health system, and across the entire enterprise, which is as patients seek care and as our community seeks care in our institution, our overarching and most important thing is we keep them safe. It is the bottom of the most important things of what we do, and aspirationally the quality of care and the services that we can provide, I guess could qualify as the ceiling. But we've had, as you know, and I hope you're very familiar with, a real focused effort, particularly over the past 3 years, of becoming a high reliability organization. And I hope you all can recite the tenets of being a high reliability organization. I think really one of the most important ones is that we have a preoccupation with failure. And I think that's the one that many of us struggle with the most. And really what is at that core is that we really wake up every morning thinking about where is there a potential for us to trip, where is a potential for us to fail, where is there potential for us to have a problem. Not because we should focus on that, but because we should focus on eliminating it. And then if we just look through our rose-colored glasses at the world, we will not see those potential opportunities for failure. And it's not just in hospitals. If you look at the rest of the world, there's lots of very high-profile disasters that you can go back and see that they have been looking at the world through rose-colored glasses. The Challenger disaster, some of the missteps that Toyota has had, some of the institutions like us across the country who are quite very prominent organizations in high reliability, and when they lose their focus, they have real challenges. So the good news is, as Rick showed you at Yale New Haven Hospital, when we began this work 3 years ago, when we didn't even have as robust of a reporting system as we have now, we know that we harmed patients, and the definition of a serious safety event, or an SSE, is at least moderate temporary harm. We know that we created at least moderate temporary harm in over 100 patients every 12 months. And if you read the medical staff bulletin that I send out to you all every month, you know that we've been reporting that number to you every month over the last 3+ years. And also, I hope that you've seen the curve that Rick showed you as that first upper left panel of his first slide. You can see that that number has been going down. What's interesting is that the total number of reported events has been really stable over the last 3 years at about 30,000 per year. And if you look at this pyramid in front of you, you can see that there were 24 serious safety events in the last 12 months. There were 1,000 precursor safety events. And just to remind you, the definition of a precursor safety event is minimal temporary harm. So what I'd argue to you is the difference between minimal temporary harm and moderate temporary harm is often in the eyes of the beholder. And if you are a patient or one of those families with minimal temporary harm, it probably doesn't matter much to you whether we called it minimal or moderate. So we're going to be focusing a lot more on these 1,000 PSEs. And then NMEs are near miss events. This is where a potential event of harm reached the patient, but the patient experienced no harm. So an example of that would be a patient received a drug that was not intended for them, but they experienced no adverse consequences from that drug. But this is really where we have a lot of opportunity to close potential risks in the future. And what you see here is there's about a total of about 16,000 of the total 30,000 of events that we classify every year end up in this pyramid. The other 15,000 are not safety events. They're maybe experience events, or they may be somehow where we have an opportunity to improve the efficiency of care. But this number has been relatively steady. But what we've seen is a real reduction, about a 75% reduction in our serious safety event numbers over the last 3 years. That's against a growth in our total patient volume. So the rate has seen an over 80% reduction, which is really remarkable. I didn't know this prior to this year's annual kickoff, but in preparation for our annual management kickoff, I went back and I looked at when we had what our last death resulting from a serious safety event was. And when I ran that data, I saw that about every other month, 3.5 years ago, we had a serious safety event that resulted in a patient death. And some of them you would be aware of because some of them were in actually this department. We haven't had a death due to a serious safety event in over a year and a half. Actually, it's been more like almost 2 years. So I think here's signal to us that what we have been doing and with regard to high reliability is actually working. We are not done. We will never be done. When that SSE number gets to 0, then we need to focus much more on the PSEs. And as I told the management staff a couple of weeks ago at our management kickoff, this year we're also going to be adding into this number, adding into this curve that we are looking at events of employee harm and events where we have hospital-acquired infections where we haven't perfectly delivered the processes of care. So I think lots of progress has been made here. I know you feel it in psychiatry, particularly on the inpatient side, but still there's more work to do. From a quality and safety perspective, this is our highest priority, not just at Yale New Haven Hospital, but across the entirety of the health system. And when you look at these numbers for the other health system hospitals, they look very much like ours. Their problems are slightly different. The challenges with regard to culture and staff might be slightly different between the institutions, but by and large, when we are solving these problems at one institution, benefit accrues to the other because of how we are now operating much more as a system. And as you can see here, we are sharing all of our learnings across the health system. We have benefited from some of the learnings, particularly from Bridgeport and Greenwich, and they certainly have benefited from some of our learnings. As I mentioned also, we're going to be doing more root cause analyses and also what's called a common cause analysis across both the PSEs and the SSEs, and we're going to continue to classify all of our events and make sure that we take advantage of any opportunities in learnings from our near-miss events. Other priorities for 2018, in addition to this adverse event composite and our patient safety composite that I just talked about under high reliability, is we kicked off about a week and a half ago a capacity command center. As Rick mentioned, we are busier than ever. One of the ways that we are looking to manage our capacity is on the 5th floor of Smilo, where we hold morning safety report every morning at 8 o'clock, patterned after how a morning report would be on one of the clinical services. We run a morning safety report that gives us a heads-up view for all of the management within the organization about what's happened in the last 24 hours and what might happen in the next 24 hours. Added on to that, this year we added a 24/7 capacity command center. What that means is we've co-located our bed management folks, our nursing resource pool folks, our EVS staff, and the other key operational folks in a single room, and we run it 24/7 in order to actually try to improve the efficiency of what we do, but also gives ourselves real-time knowledge about where there are safety issues in our organization. As a part of that, we have a daily review of every death in our organization. We have about 2 deaths a day on average in our organization. The vast majority of them are patients that are put on comfort measures only or are in our hospice virtual beds. But we believe there are additional learnings for us through that. So we're going to be doing this mortality review first at Yale New Haven Hospital and then house-wide across all of our health system. We still have an issue in DVT and PE, not on the surgical services, but on the medical services. That's going to be a focus this year. With regard to our hospital-acquired infections, again, I hope you see these numbers. I hope you look at them in the medical staff bulletin. I publish them every month. The definitions are there. I ask if anybody has any questions, and in 3 years, I've gotten 0 questions. As you see, the rolling 12-month numbers have been going down, remarkably in some cases. Our CLABSI numbers, our central line-associated bloodstream infection numbers, we had a total of 72 central line-associated bloodstream infections in 2017. That's almost half of what we saw. We had over 120 in 2016. and we had over 200 in 2015. So those numbers are remarkable. That's against a much sicker patient population, and I'm counting numbers of central line associated bloodstream infections, not rates, but if you look at the rate as compared to the total number of central lines, the number is remarkably down. We are probably one of the best in the country with regard to CLABSI reduction. The catheter-associated urinary tract infections, the story is not so rosy. We've made very little progress there. C. difficile, like CLABSI, is remarkable. There's been a group working on that has just, I think, done a remarkable job and actually won a national award at the University Health System Consortium annual meeting for their work. Surgical site infection, a lot of work, a lot of ways to go on that. Not sure how you can help, but if there is a way you can help, I'm sure we'll find it. But where we've made some progress in reduction in spine surgeries, we still, with hip and knee and abdominal surgeries, particularly colon, we still have some challenges. These, again, is really the baseline of what we should be focused on. Patients that come and seek care in our organizations should not be harmed in the process of them being cared. This is not, I think, our aspiration, but I think it is the foundation. And I think we need to continue to focus on that, and I think balance that against what our aspirations are and should be. So this gives you a little bit of background on that. We'll take some questions in a moment if there are any. Shifting gears, again, I think we don't have a lot of time, but I want to put on the table something that's really important to me, and it's important to Rick, and it's, I think, important to all of you as well, which is how do we all feel about working in this organization? How do we all feel about coming to work every day in healthcare? You know that there is an epidemic of physician burnout in the United States right now. And while burnout and engagement are not exactly the same thing, I think they are related. And we can accomplish nothing if we do not have a well-motivated, excited, interested, and engaged workforce. And to me, that includes the physicians as well. I hope you know that in 2015, we did a physician engagement survey. Doctors Joni Hansen and Sandeep Mukherjee stepped forward and said, we really want to help lead the engagement efforts at the hospital. At the time, Joni was president of the medical staff, and Sandeep has a long-standing interest as a member of the faculty in physician engagement. They asked for volunteers. They got about 75 volunteers. They've put together a physician engagement committee, and they actually have done a lot of work over the past year and a half. In 2017, in the late winter, early spring of 2017, we reassessed our physician engagement and found some really interesting findings. They differ by department. Every department has its own challenges. Interestingly, when there have been improvements, the improvements are all due to the same things: more feeling of camaraderie, more feeling of transparency, more feeling of input into the strategic operations of the department and the hospital. But when there are negative moves or when we haven't moved, the negativities are different. And I think is it Tolstoy? There's a Tolstoy quote in there somewhere. All happy marriages are the same, and every unhappy marriage is unhappy in its own way. I think there's an analogy in there. But we're going to be going back like we did in psychiatry and do departmental by departmental review of what your data is. We're actually going to be asking the chiefs to lead it, because I think that it's going to be best led by the individual chiefs of the individual departments, and we're going to give them the tools they need: their own data, your comments, blinded as best as we can, themes where we can't blind them. And I think we need to actually think about this differently and attack it differently. We made remarkable, and I'll just skip to a spoiler, which is we made incredible improvements in the community-based medical staff. On the faculty-based, not so much. It's really interesting. And in fact, if you look at the climate survey that Dean Alpern put together and ran a year or so ago, there's a lot of alignment between where the climate issues are at the School of Medicine, at Yale Medicine, and what the engagement issues are. And I think there's a lot of opportunity to join forces and try to make this a better place for all of us to work, and most importantly for the patients that we care for to get care. So there's been a lot of work in this. I think physician burnout, I think there's been some discussion, particularly in the dean's office, that we would like to engage in about how do we address physician burnout? How do we address creating a program around physician wellness? Communication improvements. We're a very large medical staff. We're one of the largest medical staffs in the country. We have over 4,000 physicians on our medical staff. We have over 1,500 trainees in our organization. We've got 19 clinical departments. Both communication within and across departments can be a challenge. We thank you for this opportunity to engage, hopefully, in some productive communication. We need more opportunities like this. Please read the medical staff bulletin. If there's stuff you'd like to see and address in there, let's talk about that. We're putting together actually a physician portal that we're going to launch in the first week of December to try to create a single point where all physicians can go for your medical staff application, to open the medical staff bulletin, to update your change in address, to have some sort of a community built within the virtual world. I mentioned the command center that we brought up. With regard to leadership visibility, we're doing these departmental presentations. Again, I think we're going to ask the clinical chiefs to take some more role in bringing the stuff that we bring to them at the weekly and monthly meetings to you all, to try to create a little bit more line of sight between what we're talking about at the leadership levels and what you're all hearing. We did a number of social events. We did 5 social events last year. We're probably going to try that again. We reach a very small number of the medical staff through these social events. The feedback was fantastic. If those of you who didn't go, we held a social event at the Stony Creek Brewery. It was a medical staff art event where we had an art show and auction entirely driven by folks on the medical staff that create art. It was well received. We had a cabaret night at the College Street Music Hall, where some of your colleagues that actually have some talent, some not, actually, there was a stand-up comedian, there was a quartet, and some other shows. It was quite fun. I think there's a slice of the medical staff that want to do more of those kinds of events. We'll continue to support those. I know that's not going to motivate and reduce burnout and engage, but it is something that was asked for. If there are other ideas, we'd love to hear about it. Joni and Sandeep would love to hear about it. So that's, again, I think with regard to what keeps me up at night, there's lots that keeps me up tonight. The Joint Commission coming in here tomorrow, the DPH coming in here tomorrow, licensure being pulled, the governor acting crazily, the president acting crazily. A lot of those things keep me up at night. But what can we do about any of those things? And from my perspective, I would really very much like to present to you next year that our SSE number has gone to 0, that our HAI problems have been fixed, that we can now get on to the really hard work of getting to what is aspirational as an organization. Not that we're not doing that now, but I think it needs to be balanced. Secondarily, I think without a motivated and engaged and active workforce, including the medical staff, we can't get any of this done. So what you all think, what you all want as part of the organization that you are part of is really important to Rick and I and the rest of the leadership team. And so what we'd like to do now is stop here and invite Michael up front, because it's important what he has to say and what his opinion is and what he may respond to in terms of certain questions. And Michael and I and Rick can engage in whatever discussion or questions you might have. And thank you again, by the way. Yes.
One of your early slides, you mentioned increased investment in behavioral health integration. Can you speak more to that?
So we have a model where Michael is the clinical service coordinator. He's the senior administrator at the institution who is responsibility. So,
and we have a dyad structure that helps us plan our services across the system. Dr. Crystal and I really helped set the strategic platform across the system. And then we have a medical director, Frank Fortunati, who's here, that works with Mark Sevilla, who's our vice president of behavioral health, and the emergency department, because those two departments are so intertwined. So what we've been really working on is just some of the things that John talked about in the state of the department, which is our inpatient reorganization that has been well received. We've been growing our interventional services. We've actually added resources to that area. And then we've looked at really creating a destination opportunity for our mood disorder center. So we've invested in BIT, our psychological counseling program here. It's been replicated down in Bridgeport now. So those are probably a couple big things. Let me briefly talk about some of the things that keeps us up at night from a psychiatry and behavioral standpoint. So through Frank's leadership, I know we worked extremely hard to look at compensation and benefits, in particular for the clinical providers. We saw that we were behind. We did very robust research and looked at our gaps. And I'm glad to say that we were successful in enhancing our shared services budget to make us more competitive in that arena. We're down quite a bit, not only here in the Yale New Haven Delivery Network, but across our system. So we're working with our site leaders across each one of them to see how we can work together. The other big thing that we're really trying to do is create more opportunities for the great residents and fellows that come through our program to stay with us. So those are a couple things I mentioned. John?
Yeah, maybe I could just add, we've had ongoing discussions with the leadership of the Cancer Center about how we could provide more effective support to the patients at Smilo. I'm not sure we're at the finish line of that discussion, but it is an important, I think, ongoing discussion. And at an earlier stages of discussion with the leadership of cardiology about how we could provide better support to patients with cardiovascular disease. That's a concern of theirs and an area of interest and opportunity for us. So those are two other areas that in the future we may be moving toward.
Hi, I'm Megan Michael, and I can actually attest firsthand to the improvements. I'm one of the founding members of Behavioral Health Patient Family Advisory Council. And in the last month, we've been in the ED twice. Once, my son had a tick bite. Yesterday, we thought I may have had a mild stroke, but it was actually a dislocated jaw. So I got to see the shift in the ED from environmental services, protective services. It was one of the most cohesive teams I've seen in a long time. But the hard work is there. The desk staff, I mentioned your name, stories came up. We have leadership that's engaged, Mark Sevilla. That's what you want, not just from the doctors, but from the secretaries that are typing things in. One of the things I have a concern with is when Epic goes down, that there are holes in that that can be filled, and I actually have someone that has some ideas for that, so I wasn't sure where to forward that type of feedback from patients, right? Because it's not medical staff. Caregiver burnout, able to give a friend from church coffee, so there's no water if you're staying 6 hours. But in terms of protective services, environmental services, the residents attending to the chaplain, I mean, that's a lot of moving pieces, and I can see that you are very, very successfully making inroads in that.
Well, as Dr. Balcezak said, we're never going to be done. So I appreciate that constructive feedback. I'm glad you and your son are both, on the road to recovery. If you have feedback that you'd like to share, just send it directly to me. I'll help get it through the appropriate team members through our organization, and we'll keep learning from that feedback. Thank you.
Thanks for your presentation. I was wondering with the safety figures and the patient satisfaction figures, what happens if you break it down by patient, SES, or ethnicity?
It's a great question. So we don't see any variation. There's a lot of discussion about performance by SES and ethnicity. One of the biggest challenges I find is most of those data are flawed because there really is no national standard about how to collect that data. So one of the things that we've been trying to do in our emergency department with our registration staff is actually develop a system-wide standard for collecting those data. You can actually, for SES, you can use, and Naomi, that there are national metrics where dual eligibility is used as a marker or as a proxy for SES status. I think it's a terrible proxy. I think it's a blunt instrument. I think it gets you part of the way there. If you just look at dual eligibility for Medicare and Medicaid, across all of our quality and outcomes metrics, there's really nothing there. There's nothing that comes out. With regard to SSEs, thankfully, we only have 25 this year, and we've actually looked at that, and we can find no patterns according to service meaning which department, according to gender, SES status, or ethnicity. What there are patterns around is the type in the clustering of what kinds of events they are. Our most common event in our institution right now is fall with fracture. That is the most common of our 24. Almost half of those are falls with fracture that require a higher level of care. And the most common, and I said we do a common cause analysis of all of our events, the most common cause that we found across all of our events, not just fracture, is a failure to follow our own policies and our own practices. And you all know that because you went through the high reliability training, there is this thing called normalized deviance, which is we know we should drive 55. Naomi, do you drive 55? I've been in the car with you. I know you drive 55. Others, he doesn't drive 55. But although the speed limit is 55, people regularly violate it. And part of that is we need to have rules and regs and policies and practices that make sense and are rational. The other is we need to hold each other, again, a high reliability principle, 200% accountable to doing that. So the short answer, and I use this opportunity, that question you asked, to editorialize a little bit. I think the short answer is no. The other answer is really we've looked at the problem, and the problem is us.
I know psychiatry is not a big revenue generating department. At the same time, we have an emergency room that is frequently filled with 20 patients every day. We have an observation unit along with an equal number. Our length of stay in the psychiatric unit is amazingly short, and a lot of people get hospitalized again frequently, and some bad events occur with the short discharges. I just wonder how you thought about that kind of issue.
So tell me a little bit more in terms of facilities or staff or programs, because we do not make decisions based on, you know, the dollar volume. They're really based on where the needs are and where our service requirements are. Is there a specific area that you're questioning?
Well, it just seems to me that the pressures on the inpatient units to get people out quickly are extraordinarily high.
They are, and I mean, that's just, that's the reality of the environment that we're in. I personally believe behavioral health is underbedded, for reasons you know better than I do. I mean, the shifts in this state and other states over the last couple of decades are profound. The payers are sending a clear message, kind of a mixed message, actually. They're unfunding partial programs and outpatient programs, and they're putting pressure on inpatient programs, and you know, which could be relieved by directing funding in alternate areas. We're doing our best to try and stay ahead of that, but it's a real challenge in behavioral health.
Can I add to that? Sorry.
Sure.
Yeah, so at Young Haven on the inpatient psychiatry units, length of stay last year actually has gone up compared to prior years. We're de-emphasizing length of stay as compared to how we had in the past. We went up almost a full day overall, or just over a full day, and almost a full day length of stay for patients who are there for less than 30 days. What's greatly increased for us is the volume of patients who are waiting a longer term bed. We have almost 20% more patients this past year who are on our services waiting for a long-term bed, and that has gone up. But just the length of stay issue, to answer Dr. Zana's point with in psychiatry, we are de-emphasizing that and looking at the same time at readmission rates and focusing on our readmission rate, trying to drive that down.
It's also worth mentioning, Tom reminded me that we're seeing that pressure across the board. Today is Friday. We have nearly 1,400 patients in beds. St. Raphael's is just under 400. We're 950 here. We have patients on med-surg units and triple-bedded units, and patients in the ED waiting for beds. You know, we're seeing it across the board. you know, and doing our best to cope with it. Yes?
I have two questions. The first question is, you tell us that we are the sort of the last to receive this presentation, and I wonder if you can tell us across all of the departments, how is psychiatry unique in, you know, the reception of this presentation, especially in the context that I feel maybe psychiatry is somewhat of an outlier. Sometimes we're not maybe as integrated as we could be. My second question is, I'm a resident and I see working across the systems that sometimes I can find processes could be improved or there are frustrations, and I wonder how I could sublimate them into changing the system, or how I might go about doing that rather than just sort of grumbling along. Or what would be a way to change feedback into something more productive?
So let me answer the first, and I'm going to ask Tom to speak to the second. The issue of psychiatry being the last is I think a timing issue. It's really important what Tom and I are doing, and with Michael and his colleagues in every department is really reinforcing a message that is a consistent one. As an organization, this is how we're doing, these are the challenges. It's really important that everybody hear the same message, we think. You know, and then in the Q&A, we kind of fine tune it to what's on the mind or the concerns of a particular department. But by design, you know, we're not doing unique presentations because we think the value of this is everybody hearing it. I think why we're here last or first, depending on how you count it, is a scheduling issue.
I wasn't saying that at all. I think we're, you know, best for last, or I was just trying to say, have you noticed that across the presentations for the departments, is there some kind of different reception, or, you know, I wonder if you notice, yes, are there commonalities or there are differences that you've noticed while
Yeah.
giving the presentation?
You know, I think one of the common messages we're hearing is just the stress of an extraordinarily busy medical center. Every single department, and it's not just physicians. I think one of the things that Tom and I we're all concerned about is the fact that we are doing really well as an organization because we are so busy, and because we're able to grow, and because we're able to manage our expenses and our high acuity in a way that is keeping us ahead of the distress that's affecting every other organization out there. Layoffs, cutbacks, it's endemic in Connecticut and nationally. You know, the problem with that is that it's putting an extraordinary amount of pressure on all of us to feel busy, hurried. We're hearing terminology like production stress or production pressure, terms like the new normal. The reality is that's what's affecting the industry, is the only, and I even hate the term industry, the only healthcare organizations that are prospering are those that are able, and by prospering I mean continuing to invest, continuing to grow programs, continuing to invest in people, are the ones that are dealing with this stress and the pressure on throughput, length of stay reduction, turnover, capacity command centers. And I think that's, you know, that's going to define the next few years on how, as an organization, we build the resiliency of our leadership, our physicians, and our frontline staff, because there's not a lot we can tell folks about how it's going to get better. There is no relief coming from Hartford. There's no relief coming from Washington, just confusion. You know, it's really hard to offer a lot of hope out there. I hate to sound so dismal that, you know, that anyone is going to come in there and make things better for us as caregivers and as a team. So that is the new normal. And we're hearing that in all of our interactions. Frontline employees, department by department, physicians, everybody's feeling it different ways, but it's the biggest common theme out there. Tom, do you want to comment on the other question?
Yeah, sure. Thank you. This is the kind of dialogue we love. I mean, I really like to hear that you have ideas about how we can improve, and I would recommend a couple things. One is what is the nature of your issues that you find? And I think depending on the nature of the issues, I think there are different places to send them. Residence-related issues, of course, Dr. Rohrbach's in the front row. He would want to hear about those. Or there is a hotline, of course, to the GME office that you should know about. If you don't, you should know about that, that anything can be reported anonymously to our GME office and can be followed up on, if that has anything to do with the training and education or how you're feeling as a resident. Regards to operations of the clinical program in psychiatry, Michael should be known to you. Dr. Fortunati should be known to you. The two of them run on a day-to-day basis the clinical program in psychiatry, and they're available to you. They should hear. If there are operational issues at the hospital, on every clinical workstation, there's actually a button that says Ask Rick. And don't laugh, we get a lot of comments. And we get some of them from medical staff, not a lot. I'm putting up a physician portal next month. There's going to be an Ask Rick, and unfortunately, there's also going to be an Ask Tom. And we're going to have an opportunity to have that. This is an opportunity for us to raise those kinds of questions. Please, don't suffer in silence. I don't know if Dr. Lu-Ming Lee is here. Is she here? Raise your hand. I'm sorry? She's away this week. She is now, as you probably know, the president of the House Staff Senate. Under Steve Hewitt's leadership, who is the runner of our GME programs at the institution, we have reconstituted the House Staff Senate because we believe that across all of House officers, as I mentioned, we have 1,500 trainees. That's 1,500 people who, forgive me attendings, do most of the work in this organization across all of our departments. They are the ones that are at the sharp end of interactions with patients, interactions with other services, interactions with our electronic medical record, and so forth. You've got lots of ideas. We're actually in that reconstitution of the Senate under Lu-Ming's leadership. We are going to actually create a quality and operations improvement structure for residents themselves to feed into our overall program of clinical redesign, which we could spend some time talking about if you're interested. So there's a couple of different ways that you can get in, and if all else fails, my email address is in every medical staff bulletin. Email me. If you call my office and I'm not there, it actually gives you my cell phone number, and feel free to reach out and let us know.
I didn't mean that we're grumbling. I think there's a lot of brilliant ideas in this
Absolutely.
room that just need to be elevated to.
And that's exactly the spirit in which I took it.
So we also had a meeting at one of the reorganization councils was the Quality Council, which included all residents from different departments, and just this Thursday was a meeting of the residents, which would elevate the issue.
I think that was under the Senate structure. So that was the first of those meetings, I believe, right? Yes, so that's the construct I was talking about. Again, I don't think there's one way we can solve these problems. I think there are multiple ways. And trust me, I was not suggesting that you were grumbling. I come from a background of performance and quality improvement. Grumbling is the rumbling of improvement, and we want more of that.
There's a question over there.
Thank you for the data on safety. It's reassuring to see the trend, and as a past and future patient, I think we're all grateful that the hospital is not as much of a source of harm as it could be. My question, I guess, is related to Hollis, is maybe more aspirational. Given the portfolio of services within behavioral health, from the ER to the ops unit, inpatient, and then IOPs, is it part of the vision of the future to have more robust outpatient psychiatry services beyond what's currently available at the St. Louis campus? And how do you think of that in terms of strategic vision?
Absolutely. So I think let me step back. So psychiatry and behavioral health service line it is a very key service to us. So it's probably in the top half, maybe in the top quarter when you look at our contribution margin percentage for the hospital. And as a result of that and the improvements that Dr. Crystal and Frank Fortunati and the team have been able to do, we continue to invest in a lot of those services. Most of our outpatient locations have all been renovated last year. So we continue to put investments in there. But more than that, we do have a team that meets every Tuesday morning. Dr. Crystal, Frank Fortunati, a couple of the other site leaders, and some of the administrative staff are looking at that quality data to make sure that those connections and those handoffs are improving. So from an inspirational standpoint, we have several, I would say, lofty goals that we're striving for. One is that we know that our facilities don't match the quality of staff and residents that sit in this room and take care of our patients. So we're trying to improve our value proposition through not just physical, but future leaders that are coming along, to add value. So it is something that we look at. We have a strategic plan. We can get our document out to everybody. I think that would be something, John, we should think about sharing. We probably look at it in our clinical areas more focused than we do and share it on a broader basis, but I think that you'd be pleasantly surprised to see the work that we're trying to do. And then if I can just say, we do understand the demands. We run 100%. I mean, this is one of the few service lines that has been running 100%. Some of the other service lines are catching up to us, and we're trying to learn, through our efforts on our capacity command center. And we are acutely aware of the challenges that we have with the increased length of stay for our observation patients. The demand is not going down for the patient populations that are seeking our services. So, how many more questions you have? Come more, please.
So I have 3 quick observations and a related question. The first observation relates to the surgical site infection data. Patients who have a history of co-occurring depression actually have higher rates of surgical site infections. Second observation is that a huge percentage of our population as adults live with chronic medical conditions, the majority of which have a significant behavioral health component, like lifestyle, obesity, substance use, tobacco, etc. Third, our healthcare trends nationally are moving from tertiary hospital care towards more population-based healthcare systems. All of these observations combined create an argument for the integration of psychiatric and behavioral health services to medically ill patients to improve medical outcomes, quality of life, and the expansion of more primary care population-based services. My question is, can you comment on where we are as an organization with respect to the integration of behavioral health into our medical services, and where are we with respect to developing more of a population quality system?
Yeah, so let me talk a little bit about our efforts on integrating psychiatry into population health, and then I'll ask Tom, if you can maybe expand outside of what we're doing. So we have requests probably from every department, for our psychiatry involvement. You're exactly right. There is no health care without appropriate psychiatric care. We work right now with several departments across our organization, bariatrics, cancer, in the primary care clinics. But the demand, it continues to outstrip what services that we have available. We're looking at how we can utilize technology and helping in some of those solutions through EPIC and the screening that we do with EPIC. We're actually looking at telepsychiatry and how we can stand up a program so that we can expand our services. It's been used across the country very effectively for areas that are underrepresented by services that we offer. But it is a challenge. I think we've done a reset in our population health strategy, so maybe Tom can talk a little bit about overall what we're trying to do across the system.
Yeah. Thanks, Michael. I mean, Michael said it. I think that, it is, I think, again, this kinds of conversations help us inform our strategy. We have been growing the behavioral interventional team, which is really one component and only one that you're talking about. And as Michael said, we have aspirations to continue to grow it and bring it to other services. But the demand is it's insatiable. Not just here, but at the other delivery networks, the other hospitals, we call them delivery networks, and also through the Northeast Medical Group. That's our physician foundation, which is a large number of primary care and specialist physicians across the entirety of southern Connecticut and southern Rhode Island. You know, I don't have a good answer except that, you know, we will always be resource constrained. We will always have more demand, not just for behavioral health services, but for all of our services. And as Rick talked about, and as Mike mentioned as well, you know, it was a time when we would run at 80% capacity except for behavioral health services. We now run 100% capacity on med-surg every day. So where do we spend our ever-shrinking dollar? Rick didn't show you this number, but we operate this Yale New Haven Hospital as a combined entity with the St. Raphael's Hospital together with us at a little over $100 million less total expense than we did just 4 or 5 years ago. So you know that everything is more expensive than it was. You know that all of our employees got raises these past 4 years. So do the math. How is it that we expanded our services, we gave all of our employees raises, and we continue to build out our services while our total revenues have gone down? We've done it through learning from the grumblings and actually doing clinical redesign projects to make ourselves more efficient. And just like any business, if you can do more with less, then you will win. The difference for us is that there needs to be a value and a quality outcome that we need to drive. And some of the ways we have driven that value and quality outcome is through the behavioral intervention team. To the extent that we can use teams like that to improve efficiency, drive better outcomes at lower total cost, that is where we will make our limited dollar investments, as we already have and as we will continue to do. So I think the challenge for all of us is, where are there actual improvements? How can we actually drive value? Where can we actually agree uniquely with the finance team that this is better? We want it from a clinician perspective better for our patients. They want it better for the bottom line. I think there are a lot more untapped opportunities that there are both, and there are synergies between those two. That's where we're going to continue. If we can show that, that's an easy win. That goes on Rick's desk, that gets approved, and there's no question. But the challenge is where do we drive those outcomes, and how do we make ourselves accountable to that? And let's be creative about it. And I think the BIT team under your all leadership, I think, is a great example of that. What other ones are out there? How do we continue to drive that value? But then it's not just for that one time that we look, but continuously. That has to be embedded into the organization. So not an easy answer, not a yes or no, not a firm commitment, but I think really a partnership that we need to continue to drive these things. Did I miss? There was something else I think you wanted to cover.
I think you got it.
When you think about the challenges of integrating behavioral health, have you looked at models from other systems that have been more successful? I just think Partner Healthcare or neighboring states that seem to have a lot more of a behavioral health component in their hospital systems, how they do that work?
Don't want that?
That's the emergency button.
I was going to say, that's a red button I'm not sure I want to hit. Yes, the answer is yes. You know, we do a gap analysis. We did a gap analysis when we looked at all of our services across the system. We looked at where we were from a current state. We looked at best practices across the country, and we identified where there are gaps out there. And we have a plan. We have actually 35 business plans that we're working on. We haven't prioritized those, you know, with resources, limited resources and time to do that. But that is something that we're always looking at. And if you have other ideas, you know, that are out there, that would be greatly appreciated. Please share. Matt?
So, Tom, you mentioned physician burnout as a major initiative, or addressing physician wellness as an initiative of the health system. I'm curious, actually, to what extent has the EMR been looked at as a source of stress or problems for physicians? You walk into the hospital and physicians spend, being a modern day physician, particularly a physician in training, residents spend as much time in front of a computer as they do in front of a patient. And qualitatively, it feels like that's a major source of dissatisfaction for faculty and residents alike.
Agreed, and we're not unique in that. In fact, we actually look at, across the health system, high-level metrics. We look at individual physicians and what their time spent on EMR is. Believe it or not, we are below most national averages. We're able, through Epic, to compare ourselves to other AMCs. Our physicians, on average, spend less time on the EMR than most other AMCs. But again, we're not done with that. I think we need to drive it further. I've absolutely heard what you're saying from other departments in these presentations. Lisa Stump, who is our Chief Information Officer, she's a pharmacist who's spent many years in the hospital. She ascended to this position a few short years ago. She would be delighted to come to you along with our Chief Medical Information Officer, Dr. Alan Shao, who's a pediatric emergency medicine physician, and talk to you about what their strategies are, and I can highlight a few of them, and get some ideas from you. Because there are lots of strategies, starting with how do you optimize from your own documentation perspective, what templates you all have built. And then there are larger strategies that we have deployed enterprise-wide. You probably have read or heard that we're rolling out something called Tap and Go, so that you sign on to the electronic medical record once in the morning, and then you can use your proximity chip in your ID badge, that you can wave it to the computer and it'll sign you back in. It saves a few seconds, but for those specialties that are in and out of the medical record hundreds of times a day, like the emergency medicine physicians or busy clinic physicians, it actually can save you 35 to 50 minutes a day. It was brought to us how? Not because our CMIO or our CIO had the idea. It's because Steve Arian, a busy plastic surgeon, said, you know what, I have a friend of mine who at another medical center has a proximity chip that we use as an authenticator rather than a password and a username. Relatively simple. It was Steve's idea. We piloted it in his clinic. It showed that it saved him an hour a day. And so we're now going to spend the time and money and effort to roll it out across the health system. One example. Two is a couple years ago, we were using Dragon. Everyone knows about Dragon. It's that voice recognition software that learns your accent, it learns your way of speaking, and through iterative learning with autocorrect, it can actually get very accurate in terms of real-time dictation. We actually piloted Dragon. We actually found an alternative program called M-Modal, and we made a decision about 1.5 years ago that we could buy an M-Modal subscription for every one of you. Instead, we put it on the health system wide, so you can now dictate your notes everywhere there's a computer that has a microphone. Not every computer has a microphone. You call the help desk, you want a microphone on a particular computer, you can put it there. M-Modal, it saves enormous amounts of time in terms of dictation. Two examples, both brought to us by physicians, both brought to us through venues like this, both time savers. And I think that as a follow-up to this discussion, I would encourage your leadership to reach out to Lisa and Alan, make a presentation. They can show you what they're working on, and then have a dialogue like this to give more ideas in structure to how we bring those ideas forward to try to improve the documentation. Electronic medical record, not going away. I was a house officer when Eclipsys first put in what was then called CCSS. My wife was the resident who organized the strike, the house officer strike. You can see how that went. It's not going away. I think it is up to us. We have a choice. We can either grouse about it or we can fix it, and I think we should choose the latter.
I think the piece that's missing here is the paid communication to the patient. So my 12-year-old could tell the person drawing the blood was kind of grumbling about entering the information to Epic. This benefits me, it benefits so many people, because even though it's taking me longer when I go to other doctors, it's incredibly helpful. So if the doctor can communicate to the patient why it's beneficial to them, the experience is actually enhanced. My family's a fan of Epic. They talk about it everywhere. So it means that some doctor, some provider made that effort to make it good for the patient.
Thank you. I think we're out of time. We are happy to come back if you would welcome us back at any point. This is really helpful to us. We hope it's helpful to you. Thank you all very much for giving up your Grand Rounds time for us. Appreciate it.